Hey everybody, welcome back to QuickSteps. It's been a while since I saw you. No, I'm just kidding. I apologize for not coming out with a video on a clearly scheduled basis, so that is my bad. I will try to make this more regular. This is a continuation of our explanation series, in which we have videos corresponding to this that are pure questions that you can try on your own with the answer choices and, of course, the correct answer highlighted. And these videos are supplement to that to better explain as well as help you practice, you, the person who will be taking the exam, where all this counts, to help you practice so that you don't have to put in as much effort come test day. You have a systematic way in order to approach questions, and hopefully you get a lot more points. So with all that being said, welcome back for those of you who are returning, and welcome to those of you who are new. So this video is on the topic of infectious disease. It is its own subspecialty, and a lot of people in it, very brilliant physicians. They are well above my head in terms of antimicrobials, in terms of organisms. Let's try to take this from a test-taking perspective and go on from there. So let's head on over to question 1. I'll read it aloud. I'll give you a little bit of time to do it on your own, and then we will go over the answer choices as well as the question and, of course, the correct answer together. So, in order to implement this method, we always start with reading the last 1 or 2 lines of the question stem, which is the part without the question mark, followed by the part with the question mark, and then the answer choices, and then we go over the whole question from start to finish. The reason we do this is because otherwise, if you read it from top to bottom, you don't really know what you're focusing in on. You might actually be able to if you've done a ton of questions and you kind of know the general gestalt of everything. However, it does save a lot more time to do it with the QuickSteps method than it does to just brute force it. And every few seconds that you save by using this method, you save brain space, you save energy, and you save time to review questions later on. So that being said, let's start with question 1. We're going to start reading from that last line where it says the patient also. Okay? The patient also reports that she recently went on a camping trip in upstate New York where she slept outdoors and ate a variety of fire-cooked meats. She denies swimming in any freshwater bodies. It's a little redundant. Which of the following is the most likely cause of this patient's symptoms? Then you have A, B, C, D, and E. Right, respectively, that is Streptococcus pyogenes infection, Rickettsia rickettsii infection, Leptospira interrogans infection, Plasmodium falciparum infection, and Borrelia burgdorferi infection. All right, so now let's read the whole question in its entirety, then I'll give you about 40 to a minute maybe to answer. A 25-year-old previously healthy individual presents to the emergency department with a fever of 39 degrees centigrade, chills, and a rash on her palms and soles. The rash is described as maculopapular, non-blanching, and slightly pruritic. The patient reports that these symptoms started approximately 2 days ago and have been progressively worsening. The patient also reports that she recently went on a camping trip in upstate New York where she slept outdoors and ate a variety of fire-cooked meats. She denies swimming in any freshwater bodies. Which of the following is the most likely cause of this patient's symptoms? So just to reiterate, answer choices A, B, C, D, and E are as follows. A, Streptococcus, B, Rickettsia, C, Leptospira, D, Plasmodium falciparum, and E, Borrelia burgdorferi. Okay, and hopefully you all arrived at the answer choice B, Rickettsia rickettsii infection. So what is Rickettsia rickettsii infection? You guys know the eponym for that? Rocky Mountain spotted fever. Right, you get these maculopapular rashes that start from the extremities, right, these soles, palms, hands, whatever, towards the trunk. Same thing with the feet. It's usually from a tick bite. And the tick has to typically be latched on for about 48 hours before you even get enough bacteria in your system in order to generate this condition. So you kind of get these fevers, not really specific, chills, not really specific. Sometimes you get a headache, right, because it's a form of vasculitis. And what also clues us in on Rickettsia rickettsii? Well, New York, right, that's typically where you see, especially upstate New York, you see a lot of tick-borne illness. You're not going to see a lot of malaria, which is Plasmodium falciparum, right? That's typically not common. You could see Borrelia burgdorferi, right, because that's also tick-borne. So how do you differentiate between answer choices B and E? Also, hopefully you're saying, at least in answer choice E, you get a targetoid lesion, right? That's usually hallmark. It doesn't really happen in every patient, but it does happen. In addition to that, it's also the nature of the rash, right? The rash typically for Borrelia burgdorferi, also known as Lyme disease, not Lyme's disease, Lyme disease, is typically either localized to that one site where the tick was actually latched on, or it could become diffuse, especially in immunocompromised individuals. But either way, it's multiple targetoid lesions. Now, this is describing maculopapular rash with systemic infection symptoms, right? Chills, fevers. And it started on the hands and feet and moved more proximally. The way I like to think about this is there aren't that many bugs or organisms that cause these, what we call hand and foot disease, right? These maculopapular rashes on the hands and feet. It's usually reserved for a few organisms, and the mnemonic that I use is actually CARS. CARS. So what does that stand for? So CARS stands for Coxsackie A, Rickettsia, and syphilis. So in this case, what do we get? Strep pyogenes. Not really consistent with anything here. Right? Strep pyogenes is not directly associated with any sort of maculopapular rashes on the extremities, especially ones that move towards the body. Rickettsia infection, we have disclosed that is indeed the answer because this patient is having maculopapular rash, had these outdoors exposures, and was in upstate New York, which is one of the hallmark areas for tick-borne illness. Leptospira is usually in fresh water. The problem with Leptospira is it usually messes with your AST, ALT, can mess with your platelets, can most definitely messes with your kidneys. We're not getting any signs or symptoms congruent with this. This might still be on the differential if this person did actually go in fresh water, but since she didn't, we don't have an exposure or known exposure. Plasmodium falciparum. That's congruous with malaria, right? Malaria infection. This is actually the nastier of the three typical malarial agents. So you want to look for location. Well, we're in New York. That doesn't make any sense in this case, or it's very, very unlikely. We don't see those kind of undulating, spiking, recurrent fevers that are either quotidian or every third day. We don't see any jaundice. We don't see any of those other symptoms where it could be affecting the liver, maybe some arthritis, those headaches. So based on exposure, location, and symptomatology, we could also rule out Plasmodium falciparum. All right, let's move on to question 2. So I want you to try this one on your own. Start by doing the method where you read the last 1 or 2 lines of the question stem, then the part with the question mark, then the answer choices, and then the full thing, and try to answer it on your own. I will give you about 30 seconds to a minute in order to do all of that. Feel free to pause me if I start again too soon. Okay, so just for time's sake, I trust that you went through our method. I'm going to just read the question in its entirety, and we're going to go over the answer choices. A 45-year-old man presents to the clinic with a 2-week history of fatigue, malaise, and a non-productive cough. He is a heavy smoker with a pack-year history of 30. He also reports that he has recently lost weight and that he has been experiencing night sweats. On physical examination, the patient appears cachectic, with bilateral crackles heard on lung auscultation. Chest X-ray demonstrates diffuse bilateral infiltrates, and a CT scan of the chest shows a nodule in the lower lobe of the left lung. Which of the following is the next best test for diagnosis for this patient's condition? A. Sputum culture with acid-fast staining. B. HIV test. C. Urinary antigen test. D. Blood cultures. Or E. Bronchoscopy. So instead of going through each answer choice, let's talk about the patient's condition overall, see if we could maybe kind of arrive at something resembling a diagnosis, and then choosing the most appropriate first initial test for that diagnosis. So this patient, fatigue, malaise, middle-aged, non-productive cough, heavy smoker, recent weight loss, but he has been experiencing some night sweats. That's pretty unusual for those of you thinking a potential pneumonia picture. He's cachectic, which also is a little bit unusual. Bilateral crackles. And he's got some sort of nodule. So what are we thinking here? Some of you might be thinking maybe this is cancer. That's perfectly reasonable. However, does cancer typically cause night sweats? Does it cause these B symptoms if it's a lung cancer usually? Also, if it is a cancer, what about the chest x-ray findings demonstrating diffuse bilateral infiltrates? How many of you are thinking about tuberculosis? Right, tuberculosis and cancer kind of have this weird junctional point. Tuberculosis, of course, is an infection, whereas cancer is not. This symptomatology is similar to what we see with tuberculosis. Maybe the non-productive cough is a bit of a throw-off, right? Because tuberculosis does have its usual productive cough. Sometimes it can be non-productive, but you do definitely get night sweats. You do lose weight. You can appear cachectic. And most oftentimes it does show up with at least one nodule somewhere, and potentially lymphadenopathy in the mediastinal area. So let's say we want to rule out tuberculosis in this patient. How do we go about doing that? What is the best first test? Well, the best first test actually is a sputum culture with acid-fast stain, answer choice A. And you typically do this 3 times. The reason why we do it 3 times is because very often it is not that sensitive. It won't pick it up right away. And you do need actually a significant amount of the Mycobacterium tuberculous, or the tuberculosis-causing organism, in order to see it on a stain. So you do it 3 times in order to increase the sensitivity of the test. Right, an HIV test, it's not really indicated here. Urinary antigen test, this is usually for Legionella or histoplasma, right? Just trying to give you a little bit of a hint here, trying to jog your memory about histoplasma, often resembling something along the lines of that which could look like tuberculosis. But once again, we don't have any obvious exposures to this. Blood cultures. Well, blood cultures is appropriate, right? Especially if you think this is a systemic infection and the patient's septic. However, that won't really make the diagnosis. Right? Unless it's disseminated tuberculosis, you're not going to really have positive blood cultures. And when we typically say blood cultures, we don't usually often incorporate fungal cultures in that, unless the patient has a positive exposure, past history remarkable for it, if they're on broad-spectrum antibacterial antibiotics, and they still do not get better. Bronchoscopy. This is a reasonable choice if your suspicion for cancer is increased. In this case, you can argue that there might be some increased suspicion for cancer. However, you definitely do want to rule out tuberculosis first. So that's why you would be doing the sputum culture with acid-fast staining, and that's why answer choice A is the correct answer. All right, let's begin reading question 3. A 35-year-old man presents to the emergency department with fever, chills, and chest pain. He reports that he had a recent trip to the Caribbean and has been experiencing symptoms for the past week. He also complains of headache, nausea, vomiting, and muscle aches. He reports that while on his trip, he went on a hike and swam in a river. Physical examination reveals an enlarged spleen and mild jaundice. Laboratory tests show a mild transaminitis, leukocytosis, and thrombocytopenia. Blood cultures are positive for gram-negative bacilli. A peripheral blood smear is unremarkable. Which of the following is the most likely diagnosis? A. Endocarditis, B. Malaria, C. Leptospirosis, D. Q fever, or E. Brucellosis. So this patient's coming in from a laboratory perspective with elevated liver enzymes, high white blood cell count, low platelets, splenomegaly, a little bit of jaundice, kind of goes hand in hand with either some sort of lysis or liver damage, which we have been seeing a reflection of in terms of the transaminitis. And his symptoms are headache, nausea, vomiting, and muscle aches. And we know that his blood is positive for gram-negative bacillus. So is this consistent with endocarditis? Hopefully you're saying no. Usually endocarditis can present in quite a broad range of symptomatology, but you don't often see it affecting the liver, the spleen, and the platelets as often. How about malaria? So malaria can affect both the liver, could affect the spleen, can definitely affect the platelets, can definitely cause jaundice, can definitely cause headaches, could cause fevers, chills, muscle aches, could cause all this stuff. But when you think of malaria, would blood cultures be positive typically? No, and we wouldn't be seeing gram-negative bacilli typically on those blood cultures. Instead, we would see on a peripheral smear some form of parasite. How about leptospirosis? Well, leptospirosis is usually when you go swimming in fresh water, especially in the Caribbean. So we have a positive exposure there. It can present, just like most of the spirochetal infections, with headache, nausea, vomiting, and muscle aches. It's usually very common for spirochetes. We have the positive exposure, we have the positive symptomatology. It can affect the spleen, can affect the liver, can affect the platelets. And the question is now, is it a gram-negative bacillus? Yes, it is. Yeah. To spoil it, of course, yes, it is. So leptospirosis is going to be the answer here. And Q fever and brucellosis. Q fever typically causes headaches, some arthralgias occasionally, can cause mental status changes, and usually causes hepatomegaly or hepatosplenomegaly, while brucellosis can cause all of those with undulating fevers and typically has more joint pain. But both of these do not coincide with an exposure in the Caribbean. So because we have Caribbean, leptospirosis jumps to the top of our differential, and that is why it is the correct answer. Let's jump on over now to question 4. So take a minute to go over question 4. Feel free to pause me, and I'm going to start reading. A 40-year-old woman presents to the clinic with a 3-day history of fever, headache, and severe joint pain. She reports that she recently returned from a vacation in South America and that her symptoms began a few days after her return. On examination, she is found to have a diffuse erythematous rash and joint swelling in her hands and feet. She also has muscle pain and reports difficulty in performing daily activities due to her joint pain. She also reports that the fever was high grade and the headache was severe and was associated with nausea and vomiting. Which of the following is the most likely diagnosis? Now let's pretend that this wasn't just purely infectious disease and we were considering a rheumatologic cause, such as rheumatoid arthritis. Is this consistent with that picture? So 3-day history, something that's acute, severe joint pain. After a vacation, so after some sort of exposure. But usually with a known exposure and an acute onset, those two very rarely are coincidental. So that meaning that if you have an exposure, right, especially if the test name drops someplace, you should be thinking a more foreign cause or some sort of infectious agent. Lupus can indeed present something similar to this, but it would be more of a subacute to chronic onset or some sort of past medical history remarkable for other autoimmune diseases without an exposure, or maybe just being exposure to sunlight. So once again, A and B are likely not the answers in this case because we have a known exposure and an acute onset of new symptoms that this patient's never experienced before. So now we have to talk about dengue fever, malaria, and chikungunya. So dengue fever can produce some of these, and you can have a headache. You can have some joint swelling, but not really all that much myalgias and arthralgias. How about malaria? Well, malaria, we said it could pretty much almost mimic anything, but typically for test-taking purposes, they try to hit all the hallmarks, right? So they will say, jaundice, splenomegaly, hepatomegaly, recurrent fevers. They'll use the word either undulating or they'll use the word quotidian every 3rd day or 4th day. And then how about chikungunya? Well, chikungunya is one of the highest yielding infectious agents that cause this sort of arthralgias and myalgias. Right, it's from a mosquito vector, right? That's its known transmitter is the mosquito. And it can cause thrombocytopenia, very bad headaches, very, very bad and even chronic joint pain. It definitely causes fevers. So whenever you start hearing about all these kind of non-specific findings with some sort of foreign exposure, joint pain, arthralgias, I want you to think chikungunya. Right? Each of these are kind of known for a very specific thing. So chikungunya is known as like the arthritis-associated fever of unknown origin as long as you have an exposure. Dengue fever, typically you get that back pain, you get transaminitis, you become jaundiced, platelets drop off. Malaria is something very similar, but it has this kind of pattern of recurrent fevers and headaches. So keep these in mind going forward, but in this case, the answer to number 4 is most likely going to be chikungunya virus because of these severe arthralgias and headaches. Okay, let's move on to question 5. So I'll give you a minute on question 5 to read through everything, try to sort out what you think is the correct answer, and then we'll go over it together. Okay, feel free to pause me if you need some more time, but I'm going to start reading. 25-year-old female presents to the obstetrics clinic complaining of abdominal pain and vaginal bleeding. She reports that she is currently 16 weeks pregnant and that she recently returned from a trip to Central America. She also reports that she had a fever and rash during her trip and that her symptoms began a few days after her return. On examination, her vital signs are stable, but she has mild abdominal tenderness and a mild cervical motion tenderness. Ultrasound reveals that the fetus is measuring at 14 weeks and there is no fetal cardiac activity. The patient also reports that she had a headache and a muscle and joint pain during her trip. Which of the following is the most likely diagnosis? So answer choice A, congenital CMV. Answer choice B, congenital rubella. Answer choice C, Zika virus infection. Answer choice D, placental abruption. Answer choice E, congenital syphilis. Alright, so let's start with answer choice A, CMV. What do we know about CMV? Does it apply here? Does it not apply here? What's going on? So you can get a congenital CMV, and this can cause actually fetal demise, typically later in the pregnancy, and the mother may or may not even experience symptoms. You typically don't experience vaginal bleeding. It is not correlated with an exposure to Central America. So we may be able to keep this on the differential, but it doesn't really seem to match every single piece of information that we have here. How about congenital rubella? Well, congenital rubella, we know that at least in adults, right, we have to look at the mother's symptomatology in order to figure out what's going on. Congenital rubella, babies are typically born. The mother or the adult might experience some joint pain, so that is kind of in line. We don't really typically see fetal demise all that often. And a good rule of thumb is to always assume that the patient, unless otherwise specified, is up to date on vaccinations. So the patient's most likely not going to be acquiring rubella from a community setting. And this is because she's been most likely vaccinated, and we assume everything else, aside from what is told to us, is unremarkable in this patient. So answer choice B has an even lower suspicion, right? So I think it would be perfectly reasonable to eliminate that as an answer choice. How about answer choice C, Zika virus infection? Well, hopefully you're saying that C is the correct answer, because it is. You can get this kind of non-specific cluster of symptoms, headache, muscle pain, joint pain, with or without fevers. Usually occurs pretty early in the pregnancy, causes microcephaly in the fetus, and oftentimes can cause fetal demise. So that is congruent with what we've been seeing, right? On ultrasound, the fetus is at 14 weeks, even though she was measured to be 16 weeks pregnant, which could indicate either some normal variance, or maybe that's because the head is small and the other organs have been affected at this point, and there's no fetal cardiac activity, which means the fetus is no longer viable. Right, so we do see that, not that often, but we do see that from areas, especially trips from Central America or abroad. So even though we established that C is most likely the correct answer, let's take a look at answer choice D, because I think this is a pretty interesting one. Placental abruption. Now that usually presents in the 3rd trimester or late in pregnancy with abdominal pain and vaginal bleeding, usually heavy bleeding and hypertension. Now this patient doesn't have hypertension, right? Her vital signs are stable and they're within normal limits. And placental abruption, the only exposure linkage between it is actually going to be with cocaine use or smoking, right? Those agents can constrict blood vessels and increase blood pressure. However, because this patient's not hypertensive and she is not late in her pregnancy and she has an exposure, these all make placental abruption very unlikely. Congenital syphilis. A lot of these congenital infections can present similarly. However, syphilis, you typically don't have fetal demise. It would usually be born with Hutchinson teeth or those saber shins. Right? That's what we always hear in terms of sketchy or anything along those lines, those study resources. And those would usually occur a little bit later in pregnancy, but you don't typically see fetal demise. You can see headache, muscle, and joint pain in the mother, but vaginal bleeding is less common. So in this case, Zika virus infection is the best choice here. Hopefully you all got that one. That was a bit tricky. Let's go over to question 6. I will give you 1 minute to read through this, and then feel free to pause me if you need more time. Okay, so we have a 38-year-old male presents to the emergency department with fever, fatigue, chest pain, and edema of the lower extremities. He reports that he has been experiencing symptoms for the past 2 weeks. On examination, he is found to have a diffuse erythematous rash, an enlarged liver, and parasternal heave. His EKG or ECG shows a right bundle branch block and a prolonged PR interval. He also reports that he has been experiencing worsening GERD and has had multiple episodes of vomiting up undigested food. He has no recent travel history, but endorses that he has immigrated from Venezuela to the United States in his early childhood. Which of the following is the most likely diagnosis? A. Malaria, B. Trypanosome cruzi infection, C. Visceral leishmaniasis, D. Diffuse multifocal lymphoma, or E. Rheumatic heart disease. So hopefully you notice these symptoms are a little bit more specific. So instead of going through each answer choice, let's see if we could figure out what the heck's going on with this patient and what fulfills most, if not all, of the symptoms most appropriately. So fever, fatigue, chest pain with lower extremity edema or swelling is a rash, hepatomegaly, parasternal heave. EKG shows some electrical conduction abnormalities of the heart, that worsening GERD. And he's been vomiting up some undigested food, which indicates potential achalasia. And his only exposure is a remote exposure in Venezuela. So if we are thinking an infectious cause for this, which it seems to be consistent with, right? Fever is usually consistent with that. He has these weird symptoms. Just think of the organ systems affected, right? We have the heart, the esophagus, the skin to some extent. So hopefully you're thinking answer choice B, Trypanosome cruzi infection, is the right answer. That's because this is one of the presentations of Chagas disease. It takes between 30 to 40 years to develop. Now, my years could be off with that, 10 years, but you get the point. It is pretty far along from its initial infection. So when you see something like this, I want you to think, okay, I see Venezuela, and now he has these heart and esophagus findings. That should already raise red flags for Chagas disease. This is a very classic presentation of Chagas disease. Now let's head on over to question 7 and our final question. I want you to take as much time as you need for this one. You can feel free to pause, rewatch the video, try it on your own, try your other questions in the meantime, whatever you want to do. But I want you to do this question all by yourself, and then I will come in and give you the assist in a little bit. So I'll give you about a minute. All right, last question. Let's perk up. A 65-year-old man with a history of chronic obstructive pulmonary disease presents to the emergency department with worsening shortness of breath and productive cough. He reports that his symptoms started 2 days ago and that he has been experiencing increased difficulty with his usual respiratory treatments. On examination, he has decreased breath sounds bilaterally and his oxygen saturation is 85% on room air. Chest x-ray shows diffuse infiltrates and a CT scan of the chest shows multiple consolidations in both lungs. The patient is started on antibiotics and sputum cultures grow gram-negative bacilli. Which of the following is the most likely explanation for this patient's infection with this organism? A. The patient has a history of antibiotic use leading to antibiotic resistance. B. The patient has a history of hospitalization leading to nosocomial acquisition of the infection. C. The patient has a history of exposure to contaminated water sources. D. The patient has a history of exposure to contaminated soil. Or E. The patient has a history of exposure to contaminated food sources. All right, so what do we know about this patient? All right, decreased breath sounds bilaterally. He's desaturating to 85% on room air. That's usually below what the goal is for COPD patients, which is usually 88 to 92%. Bilateral, multiple consolidations on CT, and he's got infiltrates diffusely. And underneath all of this, we have to piece this together with some sort of gram-negative bacillus. So the gram-negative organisms that can typically cause these types of pulmonary symptoms, right? This technically meets criteria for likely pneumonia with or without, multifocal origin, So some of the more common gram-negative organisms include Pseudomonas aeruginosa, Klebsiella, Stenotrophomonas. You can also get like Burkholderia and Acinetobacter, but those are a little less common, especially if the patient hasn't been in a hospital on vents or on any sort of lines before. And you'll notice that all of those organisms that I just said are more so associated with nosocomial acquisition. Right? So if you're previously hospitalized, we do worry about Pseudomonas in terms of gram-negatives, right? Pseudomonas, Klebsiella, and none of those fit choices C, D, or E. In terms of a history of antibiotic use leading to antibiotic resistance, that would be more associated with MRSA, or even like a VTE or ESBL producing organism, which does not seem to be the case here. This case just seems to be more in line with multifocal pneumonia secondary to nosocomial acquisition. This was a bit of a difficult question. You had to do a few logical jumps, and you may not be fully satisfied with the answer, but that answer is the most likely. That doesn't mean it's the best in terms of every potential answer that you could probably come up with, but in terms of all the answer choices here, A through E, answer choice B is the correct one. And with that, we conclude this video of infectious disease questions. If you have any questions, please provide them in the comments. Feel free to ask me anything in the comments. I'll try to get back to you in as quick of a way as I can. Have a good one, everyone. Take care. Happy studies.